How to treat rheumatic fever. Hey everyone, welcome back to our channel. Here, we discuss all the health and wellness tips that everyone should be aware of. If you haven't already or if you're new to the channel, please do us a huge favor and click the red subscribe button below this video as well as the thumbs up to stay up to date with all our future content. In this video, we'll be talking about rheumatic fever, its signs and symptoms, diagnosis, and treatment strategies. So, let's get into it. Rheumatic fever is an autoimmune disorder that primarily affects children aged 5 to 15, but approximately 1 in every 5 first-time attacks occurs in adults. The incidence is generally low in developed countries, but it is significantly higher in some indigenous populations, such as those found in Australia and New Zealand. Rheumatic fever is caused by a genetically predisposed individual's interaction with group A streptococci, which is commonly caused by a throat infection. Cross-reactive immune cells are thought to result from molecular mimicry between group A streptococcus antigens and molecules found in the individual's tissues. Streptococcus pyogenes is one of the most common agents involved, specifically epitopes from the Streptococcus pyogenes cell wall, including the M protein antigen-presenting cells such as B lymphocytes, will present the antigen to CD4 T helper cells, which will then activate the B cells to become memory cells and eventually plasma cells. These, in turn, generate antibodies against the M protein antigen. However, because of molecular mimicry, or similar molecule structures, antibodies against these antigens also cross-react with the molecules in the body. These include cardiac myosin, laminin, and molecules found in neuronal, subcutaneous, and dermal tissues. The targeting of these tissues by the antibodies results in a type 2 hypersensitivity reaction. Now let's talk about its signs and symptoms. As previously stated, cases of rheumatic fever typically occur 2 to 4 weeks after a streptococcal bacteria infection of the throat. The following are the most common findings. Number 1, fever, which is frequently a high-grade fever above 39 degrees Celsius. Number 2, joint pain. Joint pain is a very common complaint, with the most common type of joint pain being migrating polyarthritis. This typically affects the large joints, initially asymmetrically in the lower limbs and then migrating upward. Number 3, carditis. In approximately half of the cases, pericarditis, myocarditis, and valvulitis are all examples of this. These symptoms may manifest as chest pain, shortness of breath, or palpitations. Damage to the valves is less common in the first attack and is more common in subsequent attacks. Injuries to the valves can cause dysfunction, most commonly mitral regurgitation. Patients suffering from rheumatic fever are more likely to develop atrial fibrillation, heart failure, and ineffective endocarditis. Number 4, nodules. Subcutaneous nodules, which are collections of collagen that are most commonly found on the extensor surfaces of the hands, wrists, elbows, and knees, are another possible findings. Number 5, erythema marginatum. A non-itchy rash known as erythema marginatum may also appear. This appears with a red margin and a distinct center. Number 6, sydenham's chorea. This means that uncoordinated, involuntary, jerky muscle movements are a possibility. It is mostly found on the face, but it can be seen in all 4 limbs. The presence of these findings is a part of the Jones criteria, which is involved in the diagnosis and can be remembered with the mnemonic Jones Cafe Pal. The major criterion is represented by the Jones portion of the mnemonic. J stands for joint involvement. O can be pictured as a heart to remember the cardiac manifestations. N stands for subcutaneous nodules. E stands for erythema marginatum. And S stands for sydenham's chorea. The minor criteria are provided by the Cafe Pal section. C denotes an elevated CRP above 3 mg per deciliter. A stands for arthralgia. As previously stated, collaboration is required. The reason for this is that migrating polyarthritis is considered a major criterion in all populations, whereas monoarthritis and polyarthralgia are only considered major criteria in high-risk populations. Otherwise, they are regarded as secondary criteria. A low-risk population is defined as having 2 or fewer cases per 100,000 school-aged children, or less than 1 case per 1,000 for all ages combined. Anything above this level is considered moderate to high risk. The letter F stands for fever, 38.5 degrees is the cutoff for low-risk populations, and 38 is the cutoff for high-risk populations. E stands for increased erythrocyte sedimentation rate, which is 60 or more millimeters per hour in low-risk populations and 30 millimeters per hour in high-risk populations. P stands for prolonged PR interval, and A stands for amnesic, which is denoted by a history suggestive of rheumatism. The letter L stands for leukocytosis, but keep in mind that the term is used by the World Health Organization rather than the Jones criteria. Evidence of Group A strep infection with two major criteria or one major and two minor criteria is required overall. It should be noted, however, that chorea does not require evidence of a prior Group A strep infection, and that if joint involvement meets the major criteria, arthralgia as the minor criteria cannot be counted. Just as if a patient has carditis as a major criteria, a prolonged PR interval no longer counts as a minor one. So how do medical professionals diagnose rheumatic fever? We've already discussed the main lab values, so here are some additional investigations. An ECG is performed to look for blocks, the most common being first degree, but second degree, third degree, and a complete heart block can also occur. A chest X-ray may show a congestive picture of cardiomegaly, which may be suggestive of pericardial effusion. An echocardiogram would then be able to determine the extent of the effusion as well as any valvular abnormalities. A throat culture is also sent, but it is frequently negative, demonstrating the condition's post-infectious nature. Serology. In the acute setting, anti-streptolysin, a substance produced by a group A streptococci, and anti-deoxyribonuclease B antibodies may be looked for. How is rheumatic fever treated? As most manifestations resolve spontaneously, the overall goal of treatment is to provide symptomatic relief and to initiate appropriate secondary prophylaxis. Carditis is the most notable outlier. Opioids are generally preferred over non-opioid pain relievers such as paracetamol. However, non-steroidal anti-inflammatory drugs are very sensitive to joint pain in rheumatic fever. As a result, if rheumatic fever is suspected, NSAIDs should be avoided because they may mask the migration of pain, which would then be a major criterion. In confirmed cases of acute rheumatic fever, antibiotics are advised. In patients who are allergic to penicillin, an injection of benzathine benzylpenicillin or oral erythromycin is usually given. Cardiac patients who develop heart failure will require cardiac medication such as ACE inhibitors and possibly diuretics. In nearly all cases, patients with chorea will resolve on their own within 6 months. But if the chorea puts the person at risk, carbamazepine or valproic acid may be prescribed. Long-term antibiotics is used as secondary prophylaxis, with the first line being injections of benzathine benzonylpenicillin every 3 to 4 weeks, or oral erythromycin if the patient is allergic. We hope that you now know everything there is to know about rheumatic fever. Please remember to share this with your friends and family. Thanks for watching.